Okay. So this is a case of a 31-year-old female who presented to the ER 10 days after giving a normal delivery to her third child, and she presented with nausea and vomiting and epigastric pain. Her vitals in the ER were normal, and she was given just an antiemetic and antispasmodic prescription and was sent home. The ER physician did not bother to check any ECG at that time because there were no complaint of chest pain. Her symptoms resolved within 24 hours. However, 3 days later, she presented again to the ER with stroke, aphasia, and dry-sided weakness. There were no complaint of chest pain again at that time, and her head CT showed no intracranial bleeding, but there was a focal cortical infarction. The ECG on admission showed the recent wide anterior MI with Q wave and precordial leads and the remaining ST elevation. She was given aspirin, clopidogrel, low molecular weight heparin, and her right-sided weakness improved significantly within less than 48 hours. Her hospital course was unremarkable, and there were no signs of congestive heart failure. No arrhythmia noted on that admission. She was discharged 4 days later on aspirin, clopidogrel, atorvastatin, and carvedilol, and the ACE inhibitor was not given because she was breastfeeding. Coronary angiogram was recommended, but she was in a rural area with no cath lab. So she presented a week later to my office for the evaluation of the coronary angiogram. She was complaining of shortness of breath, moderate shortness of breath on exertion, and the ECG at the office did show anterior myocardial infarction with Q wave and some remaining ST elevation. The echocardiogram showed anterior hypokinesia and apical akinesia, and the ejection fraction was around 35%. The coronary angiogram was scheduled for the next morning with the expectation to see severe LAD lesion. So this is the angiogram, and this is the first shot, the LAO cranial and the epicranial, and we don't see any lesion in the LAD. So this was done from the femoral axis with 6-French JL4 diagnostic catheter. Okay, now this is the third shot and the fourth shot in the RAO caudal and the AP caudal, and at that you see there is intimal flap at the top and the roof of the left main. You can see that on the other one. Okay, so this is the spider view, and there is clean ostium in the left main and the clean 3-vessel so LAD, ramus, and circumflex. At that point, the patient was stable and normal blood pressure and no chest pain. So we were discussing about what we did see in the roof of the left main. And at that time, the catheter remained engaged with the left main. But a few seconds later, the patient started to complain of chest pain and became dyspneic and diaphoretic. And we repeated the angiogram in the AP cranial view, and that showed narrowing of the proximal portion of the ramus and decreased flow in the branches. So we did prolonged cine angiogram, and that shows subtle slow filling in the circumflex and residual staining in the left main. Let's see the angiogram. You see now that you see here that the ramus is too tight now. And this on the prolonged angiogram, there is residual staining that's reflecting dissection. And you see now at the left main, there is also dissection. Okay, at that time, blood pressure dropped to 80 millimeter of mercury systolic, and we started the support with dopamine and give some morphine. And we repeated the angiogram that now we are showing more flaps, not just at the roof of the left main, even at the base of the left main. And we thought that whatever happened was most likely dissection, spontaneous dissection after delivery. And that's just because of the catheter the catheter touching the vessel caused a dissection again. This is the angiogram. You see now there is a flap at the top and the bottom of the left main, and there is this staining with the dissection and this, slow flow. So what to do next, and why did that happen? So I asked Mr. Newton, and he said probably it's just friction from the catheter with the left main in this frail area. So what's next? We asked Tom Cruise, and he said that mission impossible, we cannot do anything. Without the help of Spider-Man and Superman, and he offered just let's escape from that window. And yeah. So only Hitchcock offered to do the direction for this horror movie. So there were no option to do anything except for intervention. Now the patient's having chest pain, dropping her blood pressure, and we are losing all the 3 vessels. So we switched directly to 6 French guiding catheter, XP, and we did triple wiring, blind triple wiring of all the 3 vessels. And we started to do just inflation at the left main. So this is triple wiring. You see there is wire in all this, and we did just balloon inflation at the ostium of the LAD. Just after ballooning the LAD, we got improvement in the flow in the LAD and at the ramus. We did not do anything to the ramus, but we showed the improvement in the flow of the ramus. There were extending flap in the circumflex, and there was very slow flow in the obtuse marginal. So we decided to implant stent to stop the progression of the dissection. This is before the angiogram. After just doing ballooning to the LAD, you see improvement in the LAD and improvement in the ramus. Now we don't see staining in the ramus. We did not do anything to the ramus except the wiring, and you see the flap in the circumflex and very slow flow with staining in the OM. So this is after nitroglycerin. So this is again in the spider view, showing that still there is a flap in the roof of the left main and flap at the bottom of the left main. So at that time, Superman came back and he said, it's time for stent. So we implanted the first stent, and the first stent was in the circumflex, from the ostium of the circumflex to the mid part. And this is, at that time, we decided just to reduce the cost for the patient. This was a bare metal stent. Okay, so this is after the stent. And we see now still have good flow in the ramus, and there is a good flow in the circumflex, but there is still intimal flap. So this is after nitroglycerin. Now we got improvement in the flow to the OM after stenting the circumflex, and we don't see any flap. The ramus appear to be safe, and there is a flap in the LAD and flap in the left main, whether at the top or the bottom. So we decided to put another stent. We put another stent to the LAD, and this is again from the ostium to the proximal part of the LAD, and again this was a bare metal stent. Okay, and this is after stenting the LAD, and we got a good result, and we did not do anything to the ramus at that time. Would anybody do anything to the ramus? But still there is flap in the, at the top, at the bottom. So anyway, so with that we decided not to do anything to the ramus, but just to calculate the flow in all the 3 arteries. We came with the help of Einstein with this stupid idea to calculate the velocity and the length of the vessel. And from the frame count, this is very simple thing, you can calculate the coronary blood flow. We assessed the coronary blood flow in the 3 arteries by using this simple thing. That's the Kelly and the legs of the wire.
Spider-Man.
Just let's get back just as well. So you put a Kelly at the end of the wire and then withdraw the wire to the ostium of the artery and put another Kelly, and with that will give you the distance between those two Kellys, and that's the length of the artery. And from the frame count and the diameter of the artery, you can calculate the volume of the blood and the coronary blood flow. We calculated all the three arteries and it was equal, so we decided not to do anything to the ramus. Just remember, we did not intervene to the ramus at all. And this is the final angiogram. We decided to take the wire, just do post-dilation to the LAD and just take the wire out. And this is the final. And we decided just to keep this flap because we sealed the flap. Anyway, the patient did very well discharged. We did stress test 6 months ago and it was negative. And I kept pushing her to get repeat angiogram. She refused for the cost. So I offered her, I'll pay for that. So she accepted. Yes, you pay for that. And just remember, this is her right coronary artery, and this is her LV gram showing apical akinesis and possible thrombus at the apex. So this is the angiogram at about 16 months later after I paid for that. And this is normal coronaries. And everything is sealed. And no flap in the circumflex or no flap in the LAD or the ramus, and the dilation of the left main, but without any flap. And this is the right coronary artery. And this is the LV gram showing improvement. Still, there is apical akinesia, but better LV function. And with that, I got the victory. I did discuss that with my mentor. This is Mike Gibson. I'm sure you know, everybody knows who's Mike Gibson. And he said, well, this is like Nadia's achievement in 1976. Nadia Comaneci, who got 10 out of 10 in the Olympic game in 1976. And he said, well, wiring 3 vessels without IVOS and to be in the true lumen, that's 310. Putting 2 burst metal stent at the ostium without affecting the ostium of the ramus and the left main, that's another 210. Having no restenosis, that's another 10. And there is 10 all over, and you got 7 10s, like Nadia Comaneci. Everybody knows who's Nadia Comaneci.
Thank you very much.